Everyone being here today. First item of business, we need to approve the minutes from the December 1st meeting. If people can take a look at those and keep taking a look at that. Let's have a motion and a second to.
Move approval.
Okay. I have a move for approval from Dr. Wagner, second from Charlie Nimrod. Any further discussion? Hearing none, all in favor, signify by saying aye.
Aye.
Nay. Opposed, nay. Everybody abstain. Hearing none, let the record show that we had unanimous approval. I'm gonna take a moment of kind of privilege here. I've asked a couple people here to say a couple words about somebody that was very meaningful to me, meaningful to the state of Texas, was instrumental as we established the Texas Child Mental Health Care Consortium, and that's Sonia Gaines. And some of you may not know that Sonia passed away back in December. And there was a memorial service for her last week that some could attend, but others of us could not attend. But you know, she was such a presence, such a positive person, and changes that she made, being tapped by Commissioner Janik after direction of Senator Nelson to really help us think differently about children's mental health services here in the state of Texas. And she did that after doing tremendous work in Tarrant County and getting us beloved by many of us. I thought it would be appropriate for us just to spend some time just observing that. And Danette, I asked you to start off, and then Trina, if you would start off, but just remembering our colleague comfort.
Thank you for inviting me today. You asked me if I would be willing to come by remarks. I told you that I would do my best to get through it. But I do appreciate being here as this executive committee. Sonia was a strong part of the inaugural committee, as I was as well. And to talk about the leadership legacy that she leaves behind. And as it turns out, honoring Sonia's life, her extraordinary leadership and her lasting impact across the Texas behavioral health system has actually helped me, and I know many of us, navigate the grief of losing a remarkable leader, a trusted colleague, and a true friend. Everyone that's here today in whatever capacity, joining remotely or present here in the room, knows that Sonia was a courageous leader who understood instinctively that lasting change requires winning both the hearts and minds of decision makers, of the thousands of Texans who show up every day, live with care, and of the people who and families who rely on that care. Sonia was a master at telling the story of a system that has value and a system that requires attention. In just a few short years, she changed us from a system that was tolerating long waiting lists for people to get into care to one that has made investments to ensure that the local systems are able to ensure that the lights are on and the doors are open when the next person comes in need of care. From spearheading the first comprehensive behavioral health strategic plan and stewarding more than $6.7 billion in behavioral health funding across 18 state agencies, and I think it was actually more than that by the time all was said and done, and even today, to advancing mental health first aid, peer support services, yes waiver services, certified community behavioral health centers. I'm just naming a few here: coordinated specialty care, multi-systemic therapy, 988, crisis disaster response, ensuring that we're there when communities are in need. Sonia had a hand in reshaping the landscape in Texas. And just in a little bit more than a decade. And yet, I know Trina, you would agree with me on this, and as you would as well, Dr. Leahy, Sonia would be the first to tell every one of us that she did none of this alone. She collaborated relentlessly, mentored generously. Many of us benefited from that. And she trusted deeply in the people around her, bring a shared vision to life. She would also remind us without hesitation that the work, our work, her work is unfinished. In March 2024, many of us gathered to celebrate Sonia's retirement from state service. Dr. Leakey, I remember you being there as well, Trina too. In thinking about that day, I am grateful that we did not hold back in expressing what she meant to us personally and professionally, and that we were honest about how hard it was for us to imagine the Texas mental health system without her leadership. Even as we wish Sonia and Amos, her husband of 48 years, all the joy, the travel, and the time that they had ahead with family in retirement. Serious illness that Sonia faced just months later was not what any of us hoped for. And it certainly was not the retirement that she and Amos dreamed of. Still, each of us should find comfort in knowing that through their shared and deep faith, they found all the joy and the love and the meaning and the time that they had with each other and with their family, and in particular with their grandchildren. So yes, Sonia's legacy lives on in the system she strengthened, people she mentored, and the lives improved because she believed Texas could do better, giving people the hope, reality of recovery. Most meaningful way that we can honor her is to carry that belief forward, to finish the work she so passionately advanced, and to lead with the same courage, humility, and heart that defined her life. Thank you for having me here today. Trina.
Thank you, Jeanette. So I was thinking about today, I couldn't quite find the words on page. So much of it has been articulated, I think, in the different celebrations that we've had, honoring her life. So I'll reflect back on when I first met Sonia. She was actually at Tarrant County. And we were transitioning the behavioral health system at this agency level. Then at the time, Department of State Health Services, where the mental health and substance abuse division was located for transformation. And we were transforming from resilience and disease management to Texas resilience and recovery. And I remember thinking, oh, this is good. And she had lots of thoughts and opinions about the direction we should be going in. And then, some years later, as Dr. Licky mentioned, she got tapped to be what we affectionately dubbed at that time, a mental health czar. Being Shannon Yeager at the state service operation from her talked about that and how she had been identified to take that route on to build that strategic plan that so many of us reflect on. And then she was tapped to step into the role of Associate Commissioner over local mental health and intellectual and developmental disabilities for the state. And she tapped me to be number 2 in terms of stepping in as a mental health coordinator. And I assisted, I was just telling you. But she had this uncanny knack for pushing. Jeanette talked about mentorship, and I have had the benefit of spending many years in her mentorship. To really ready me for the work that I do today. And so both honored. been part of this work with her. And to be in service. She was very committed to service, to her family, to community. And to building a system. Everybody could come and know that they were gonna be cared for. And we spent many hours early in the morning, late hours talking about how we really implement this work. The limitations that we have. Funding and resources. But we always find a way, as best we could. So I hope that the work that I do, be able to honor her memory. And continue the legacy of service, that she's so committed her life to. I used to say to her, we would have challenges, get financial legislatively or implement something. I said, why is it so hard to help people, right? But she was always, to the points that were raised here, and I think also too at the celebration, she was just positive. She just kept going. And so I knew how to do. So, and we don't like people the opportunity to speak and honor her.
Thank you both. One of the things that I really respected about Sonia, and I was thinking through the conversation, is he didn't hesitate to challenge me. I always knew where she was coming from. What's best for the patient? Are these things that you're developing duplicate something else that's going on? And how do we make sure that we don't do that? How do we get programs to work together? That being very thoughtful, professional, passionate in those conversations, that, challenging us on how we can do better. Our heart was in the right place. Anybody else? I don't want to drag this out, but she was such a important person in improving the mental health system here in Texas. I just wanted to spend a little bit of time just honoring her. And you both. And then you did better than I thought you were going to. And I don't mean in the presentation, I mean, in our conversation was, I'm not gonna be able to hold it together through this. Yeah.
So I noticed with Trina, who was speaking from her heart, I too, speaking from my heart, but I knew if I didn't put it down in words, that I would be in that same place. But quite frankly, that's an important place to get to, because it's important for us to know that that grief is there and to face it. And to always, I was actually thinking about this, I was thinking there's something about Sonia. And sometimes it's difficult to grasp exactly what it was about Sonia, but it comes back to what you're talking about, lady. Never back down from a candid, forthright conversation, but she always did it with such heart that you knew that where she was taking you in your thinking was an important place to go.
Keep it on the way that you. Thank you both. So with that, let's proceed in the work that she was such a passionate supporter of. Let's start with the budget update and legislative updates. Rachel, I'm gonna go to you first for the update on the bills from last legislative session and the work that everyone's been putting together and the work you've been leading. Make sure we implement what the legislature asked us to do.
Thank you, Dr. Lee. So I'll give just some quick updates. Please let me know if there are any questions. I'll first give an update on HB 18. This is our rural hospital bill. And for the consortium, we have two components related to this bill. First, related to CPAN expansion to rural hospitals. We are almost ready to go with this portion of the bill. We have everything ready. We're just waiting on some external communications, and then we'll begin outreaching to rural hospitals and enrolling in our CPAN program, taking consultations from them. For TChat expansion to rural hospitals and rural clinics, we are making really good progress here. We are finalizing our participation requirements for our HRIs and rural hospitals and clinics who will be part of our initial rollout. So HRIs, you all should receive that soon in the next few months here. We're aiming to go live with that portion of the bill in early FY27. And then for both pieces, we are also finalizing our evaluation plan, and thanks to our internal evaluation team for that. HB6, so this bill has a number of requirements for our TChat program. I'll touch on a couple right now. One, the legislature put additional requirements on us to report on additional data in our biennial report. One of those pieces of data is about information shared about our consortium research programs with TChat families at discharge. And that change has now been made in trait for us to capture that data. We are also required to post a process for vetting the resources that we share with TChat families. And we have prepared a policy that outlines those expectations. That policy right now is with HRI leaders in our TChat, CPAN, and PeriPAN programs. And we're aiming to have this to you all for an introduction at the next meeting. And then finally, our third-party billing rider, this requires us to explore options for third-party billing in TChat after the 4th session. And we have been working with a consultant who has begun interviewing staff. And we are also collecting right now data on insurance status of TChat patients for FY25. Any questions?
Very good. Any questions from anybody in the room or?
Rachel, on that, this is Nelson, on that CPAN implementation for HB 18, is there just certain HRIs participating in that, or what is that rollout supposed to look like?
This will be a statewide rollout, Nelson.
Okay. Thank you.
Other questions? Hearing none. Thank you, Rachel. Alex, let's go to you for the update on the budget.
Good morning, everybody. So for FY26-27, as we have in years past, we will be re-budgeting our FY27 budget. And you all should have received your exercise to do that last Thursday. Like in previous years, we're looking for shifts. We're looking for some right sizing. Please, let us know if you have any issues in the current year, but this is again focusing on FY27. You should have also received your exercise for your FY28-29 budget request. And again, next biennium, we will be entirely on GR. So our entire request will be on those GR funds as ARPA is set to end at the end of FY26. To help with that, I will be hosting twice weekly office hours on Tuesdays at 11 and Fridays at 9. You're encouraged to attend, just drop in. If you have specific questions, please bring them. If you just want to watch other people ask questions, that's totally cool too. So whatever you like, and if you, need additional support or a one-on-one meeting, I'm happy to do that. That's what we have going on right now. Any questions?
We got any questions for Alex related to the budget?
Thank you.
Hearing none, I'm going to add something really quick. We've added a couple of people to our team, and I'd like you to introduce them.
First, I'd like to introduce Stephanie Ross. And she has joined us as the TChat project manager. Stephanie is in the
Yeah, my name is Stephanie Ramos and I just joined last month.
Second person I'd like to also present is Margaret Ballard. Margaret is the research project manager, and so we'll work with the data committee and also NECMR and a lot of.
Very good. It's good to have you part of the team, so thanks for being. With that, Lainey, let's go to you for the update on communications. I was told that you may be out. You may need to move just this way, just a little bit, or lean way in, so to make sure that you're visible, and to people in the audience. But again, thanks, Lainey, for all the work that you do related to communications and updated for what you've been doing.
Absolutely. Good morning, everybody. I just wanted to provide a couple of reminders. You've heard me many times before say this, but just a reminder about our 10-day communications policy. So we do ask that your teams are submitting materials that you need review and approval for, that we are respectful and considerate of our time and our Kosh members' times. So giving us those 10 business days is crucial. So we can do a thoughtful review, get you any edits, work with your teams to get those revisions made, or provide approval on first review, whatever happens, but we appreciate the time. So that we can be thoughtful and considerate with those edits. The other reminder is to keep us in the loop about media inquiries. That includes op-ed opportunities, any interviews, even if you're just providing brief comments or you feel like it's not anything major, maybe it's something small to your area or things like that. We love to be in the loop for the opportunity to reshare those moments. We also want to be able to help. So if you need any type of media prep, if you need help with data, if you need help with anything that may be out of your scope, but you know is still related to the consortium, we are always here. Happy to just jump on a quick call and talk through some potential questions, help you with talking points, help you with things you want to say or don't want to say, whatever you might need help with. So we're here to support with those as well. I just want to have those as a reminder, and that is it.
Very good. Any questions for Lainey? All right, seeing none, we're gonna go through the updates of our various programs. And Dr. Pliskett, let's start with you from the CPE.
Okay, good. Can everyone hear me okay? Wait for the bring up the PowerPoint and get underway. So I'm going to review some data on the community psychiatric enforcement programs and also on the capital programs. The latter will focus on what the placement of residents are post training. Next slide. So first with CPB. These are some definitions here for those who are not familiar with many acronyms that we have. Next slide. And these are the metrics for the CPB program that were developed years ago. We're interested in the number of faculty that are assigned, residents assigned, number of unique patient visits and unique patients seen, the ratio of children seen to total patients, because some of our programs work with adults. Next slide.
Do you think the microphone may do better, just a little forward?
Yeah.
Yeah. And then face towards you.
Oh, very good. All right. There's one metric here that'll be the focus of a action item. Time from intake to first prescriber calendar spends inactive on 21. Also, we are working on ways to measure the number of people who come into LMHAs through CPAT or TChat. That's still in process. We will not have that. As I say, we'll be looking at placement of residents post-training. Slide. This shows the funding of people in the CPB program. This is just MD faculty and MD residents. Of course, we have an array of other workforce expansion programs for non-psychiatric providers that Dr. Brenner oversees. I'm not going to be saying a lot about that today. You can see the vast amount of funding comes directly from the state CPB funding, with a variety of funding from the CAP fellowship program itself, as well as part of the company. This represents the number of unique residents and faculty who are rotating through CPB, and this is based on the current fiscal year to date. The see that roughly 2/3 of these individuals are rotating through elevations. That and now we've now reached 100 people at this point. About a third of people in the program overall are rotating non-elevation community agencies. That for as far as faculty are concerned in the lower left, vast majority of these individuals are employees of the HRIs, a small number of facility physicians, psychiatrists are involved in supervision. Slide. And this represents the average FTE across the site September to November. This basically would tell you on average in a given day, sort of the capacity that's present. And we see that we have about 49 FTEs on any given day in the LMHAs, almost 16 in the non-LMHAs. On the right, you can see the number of different settings people are in. Outpatient accounts for the vast majority of that, but we do have some fairly unique rotations in with assertive community teams, developmental disabilities, and first episode clinics. Now this, I thank Dr. David Wheaton and the council for getting this data together for us. These are the unique clients and client encounters at all of the LMHAs for all of fiscal year 25, which of course ended August 25. You can see that almost 7,000 individuals were served, and that represented over 20,000 patient visits, roughly 3 visits per individual. And you can keep it about fast. Almost all of these are psychiatric encounters, likely to be people that are getting medication management, as opposed to ongoing therapy. This actually represents, I think, a fairly good amount of engagement. David Lynch and I are developing methods to track this data in the non-LMHAs and also to start doing it on a month-to-month basis for the current fiscal year. And we can incorporate that into our updates at future meetings. Now we're going to look at some of the placement summary data. So again, the goal, one of the chief goals of CPW, as well as the CAP fellowship, increase not only the number of child psychiatrists graduating from programs, but to increase the capacity in the public medical center. And I think we make short here. Let's hear more information on the metrics that you can your leisure. Next slide. So the data that we have looks at 48 CAP fellows and 43 CPW residents, that is general residents who rotated through CPW either in adult or child rotations. And you can see that nearly 80% of these people after graduation are in Texas. Many of these people are in a public setting, 46%, or they're in a nonprofit setting. And 27% are in the for-profit setting, which I believe includes private practice. Although some of my friends in private practice would say, what do you mean for-profit? So that clearly shows that we're meeting one of our key metrics, which was to make sure that people in Texas benefit from this program, but also we're seeing good representation in the nonprofit sector.
So it's about 3/4 of the people that have gone through this program are ending up in the public or nonprofit sector of mental health services in Texas.
And it's great.
I think that's a pretty good statistic.
And
I think that we need to get more down.
And joking aside, I think they've looked at some of it having private practice where you're seeing patients with Medicaid or CHIP, or actually our stories of uninsured people. So we'll need to drill down that. Again, this just reiterates that the vast majority of people are working in outpatient settings, a decent number in inpatient, and there are a variety of other weak sites that people are in that will have more data on future, and nearly 3/4 are in settings that do treat children. Now here's our action item. We have this 4 years ago item. We're going to track the amount of time that it took for an individual to go from their intake to their first prescriber visit. Thought this would be a good metric for looking at psychiatric capacity. Additionally, in LMHAs, people come for an intake visit where their overall clinical situation is assessed, and then they're given appointments for 2 other providers. And in many LMHAs at the time, there might be a big gap between that intake and when they got to see a psychiatrist. This metric has not been proven practical to measure for a variety of reasons. One is it's simply difficult to track, get that data, but more importantly, there's just huge variability. And in many cases, the first appointment is with a psychiatric provider because that has been particular focus, particularly as we develop the LMHA, TChat to LMHA pilot. Very often people continuing their psychiatric meds as sort of a priority, so that the metric would be 0, so it'd be largely meaningless to track. So recommendation of the leadership group is that we simply delete this metric, and that is the action item that I'd like to put on the table after taking questions.
Any questions in general first, and then we'll go to the action item? Any questions from any of the members of the executive committee? Justin, Steve, one I think kind of number that it'd be nice to find would be that 6,700 clients that we've seen. What's the denominator of the number of people that the local mental health authorities saw during that time period for those that were in? What percentage clients that served through?
So we can look at that. I think with we've also in the last year had a lot of really nice collaboration between Texas Council and themselves, which I think can give us access to richer data in the months ahead. So
Let's go one slide back. This is the recommendation from Denny.
it is formally
We have a motion by Dr. Blitzka. And a second from another executive committee member.
Second.
Second?
Second.
Any further discussion? Hearing none, all in favor of deleting this metric, signify by saying aye.
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 Those nay? Anyone abstain? Let the record show that we had unanimous approval. So now we go into the presentation from Dr. Brenner related to the CAP program and the other workforce expansion initiatives. Adam, I think I saw you, right? There you are.
Yes, thank you, Dr. Lakey. No slides today, and I'm going to focus on the CAP fellowship programs. The limiting factors about, as we've talked about in the past, about continuing growth of the CAP slots around the state are making sure that the program directors have the educational bandwidth and teaching resources, and making sure that we are continuing to grow the pipeline into child psychiatry. So in terms of the first, having the resources, we've identified that the most valuable thing that we can do is share resources across the state. So one of our work groups, led by Denise Bond, is creating a shared didactics event that will happen quarterly starting this coming year. She is now in the phase of the dates have been set, and she is recruiting and scheduling the actual speakers. The 4 topics are going to be child psychiatry and the law, eating disorders, addictions, and technology and child and adolescent psychiatry, mental health. So those are the 4 topics for this first year of rollout. In terms of work on the pipeline, we've been talking about the idea of having a Texas recruitment reception at ACAP. That's challenging in a number of logistical and administrative ways. Very grateful to Rachel and Claire for joining us for these meetings and clarifying what we can do, what we can't do, and how to move forward. So more to come on that. The other thing that we're doing is that Taiwo Babatope is taking the lead on developing a virtual recruitment, a 75-minute event that will be aimed at all medical students and general psychiatry residents throughout Texas. We're going to try to launch this in the fall. It's going to cover what are the varying paths to child and adolescent psychiatry, because there is more than one way to get there, and this is something that's often not clear and a little bit confusing. And then why Texas for child and adolescent psychiatry? Because we think that, particularly with the TCMHCC, that we can make a very strong case for why this is really one of the best places to be if you're pursuing training and launching a career. And then finally, this will be the opportunity to share what all of the individual fellowships are. So those are the core projects that we've been working on. I also want to just share this appreciation, which is that I think that the quarterly meeting of the CAP Fellowship Program Directors has started to become a place where the program directors can open up with each other and talk more about the stresses and the inevitable disappointments that come along in this work, and that sometimes go unspoken. And in being able to do that, I was very impressed that one program director then was able to share that they had a new teaching need that had recently come up unexpectedly, and that now our network will be able to work on outsourcing that teaching need among places that have a little bit more bandwidth. So I'm just very impressed with the openness and the willingness to share at these meetings. Appreciate being able to be part of it. That's all for today. Thank you.
Thanks, Adam, and thanks for facilitating that kind of conversation. Really, I have learned over time, getting people who do the same job in Texas into regular conversations does so much for both them and the program. They learn from each other, and spend the year of their peer on how to approach problems and share those challenges, and it really helps improve the work that we do. So thanks for doing that. Any questions, Brad? I see Dr. Amador. I see your hand.
Oh, hello there. Good afternoon. Good morning. In regards to the lectures, is it something like, for example, if a resident can't attend because of they're on service or something, will this be recorded for them to watch later?
We are, yes, that's our intention, but we're going to be, we've reached out to all of the CAP fellowship directors. Denise Bond has to find dates that work best for the programs and that are consistent with the didactics that are already in the programs. But yes, we're also hoping to have it available for recording for those who can't attend. We like the idea of everybody attending at the same time because, again, we want to grow that sense that as a child psychiatry resident in Texas, you're part of something bigger.
Then Adam, I probably should send you something. The Texas Higher Education Coordinating Board came out, I think, a week ago with the awardees of the expansion of graduate medical education that the legislature funded last legislative session. And looking through that, if I recall right, there were quite a few of our institutions that were able to expand general psychiatry and some additional slots, and so let me make sure that that information is available to you. Any further questions, comments? Hearing none, let's go to Dr. Wakefield and have the update on Perryman.
Hello, good morning. Oh, there it is. All right, we can get started. Great. Happy to talk about PeriPan today. I think we talked about taking the slide out just because we have the information on the next slides. So let's go there. There we go. We had, so wanted to show you, I know this is a really busy slide, but I think it's a time well spent to kind of look through it and the increase in consultations over the last few years. We are really excited about, obviously, and have been working towards. You can see when the original pilot began and then the statewide launch, and how those have been increasing year over year. Next slide. When we look at, again, this was a question asked probably a long time ago. I don't know if you guys are still interested in this data, but we still can continue to present it. And the kind of baseline data is that 68% of our callers are physicians when we think about who is calling PeriPan. Of course, we have the line available to nurse midwives and to other types of clinicians and advanced practice providers, and to call us and for guidance as well. But almost 70% of our callers are physicians. And so looking at that breakdown of physicians, our most common caller, almost half are obstetric clinicians. And then our next most common are our pediatrician colleagues, and then our psychiatry colleagues and our family medicine colleagues after that. I think this is really important information for us to think about when we think about outreach and engagement, and what kinds of tools that we develop to help support our clinicians. Many of them, these are very different clinicians when we think about the different practices here and what their needs are. So our obstetric clinicians are very busy surgical subspecialists who are running around, delivering babies, doing surgeries in clinic a portion of their day or a portion of their week, but not the majority often. And so are very busy. And how do we provide them the support that they need in a very real time and an efficient and effective amount of time? How do we provide them tools that may be outside of the consultation line as well to facilitate as much, expediency of that information, of that accurate information? I think about our pediatricians who are normally seeing moms in those well baby visits. They have a high burden of screening for postpartum symptoms for moms, as recommended by the American Academy of Pediatrics in that postpartum first 6 months. But they're not mom's primary clinician. So how do we help support that pediatrician when they're calling us in next steps and how to coordinate care for mom? And then our psychiatry colleagues who often have a more foundational knowledge of the mental health aspects of what's going on, but lacked in their training often any information about what happens during pregnancy and postpartum and what are the most safe things to do. So I think this continues to help us when we're thinking about what kinds of consultations we're getting, how to differentiate what that clinician's need is when they're calling us, and then also in the tools that we develop, how to facilitate those tools in the best way for these different clinician types. And I think this is a unique issue for PeriPan and something that we continue to think about. Next slide. So this is a slide thinking about how often the call is actually going to the psychiatrist, and why this is important and why we track this is because when we look at data, mostly from the Massachusetts program, because it's been around the longest and has the most data, but when we look at outcomes data about changing the behavior, driving new behaviors in that frontline clinician and expanding their capacity to assess and respond and effectively treat mental illness, we know that much more helpful or that the data currently, sorry, I'm trying to turn off these notifications so they're not loud. the data currently is that frontline phone call that just goes to the behavioral health specialist to help with resource and referrals doesn't actually change that practice. It helps get the patient to the right resource that they need, which is a good thing. We want to continue to do that. But our real goal in the Access Project is driving the change behavior of that frontline clinician and helping support them in their confidence and capacity to respond to mental illness presentation. And so we know, based on the data that's existent currently, that getting that phone call to the psychiatrist and having that clinician-to-clinician discussion drives the change behavior. And we'll talk about in a moment that going to that direct patient consult drives that change behavior even further. So it's really important to us to think about how many phone calls are going to the psychiatrist. Across the nation, the standard seems to be about 2/3 stay with behavioral health specialists and 1/3 go to the psychiatrist. We have really tried to drive that higher for Texas because thinking about how important it is about our mission to change for that capacity building. So I'm happy to reflect that we continue to have higher than 1/3 going to being transferred to our psychiatry clinicians, specialists, and it's something that we talk about at all of our repro psychiatry meetings every month about how to help our teams feel comfortable and confident in transferring that phone call to the psychiatrist. So in December, we had more than half of those calls going to the psychiatrist. So very excited about that statistic or that data point. Next slide. And these are our direct patient consults. We've had a dip recently, probably due to the holidays and people not going to the doctor as much. We're hopeful to see that spike back up in the coming months. So we'll continue to track it. But overall, we still have an increase from when we launched direct patient consults, which is very important. And again, why we are tracking this is that the more we do these direct patient consults, the existent data tells us that the more we drive that change behavior and increase the confidence level of that frontline clinician and increase their ability to say, I saw the same thing, or I didn't see the same thing. I didn't notice that. Thank you for, evaluating this patient and telling me what you saw. Next slide. Just wanted to give you a few updates on some projects that we've been working on and that I've talked about multiple times here before. Our Pathways project is the PCORI that we are participating in. It's a nationwide project to really increase improve the response of an individual clinic to assessing for mental health distress in our pregnant postpartum patients, and then knowing how to respond to those presenting complaints. We know that, I've presented the data before, that just recommending screening has not changed the practice very much and has not moved the needle as much as we want to. And so the Pathways Project helps us go into the clinics, help them understand how and when to screen, when their downtimes are, what to do with the positive screen, how to respond, what psychoeducation to give, and when to refer that patient, and when to use PeriPAM. So we're really excited about that. Our very first cohort has launched with implementation meetings in January with UTMB site. So thank you, UTMB, for being our first site for our Pathways project. And we continue to attend our Pathways Program Advisory Council meetings and work across the nation to learn from others doing this as well. We are also working with Lifeline for Moms. We've submitted some presentations about the work that we're doing primarily around our education. There's not, as far as I know, another program in the country really pushing the education as much as we are, looking at all levels of education for obstetric clinicians, for our psychiatry trainees, and really this comprehensive webinar and ECHO series in addition to our toolkits. And so we wanted to talk about that and share those lessons and what we've learned and what we're doing nationally. So we're excited about that. And then we were able to meet with some legislators from Iowa and educate them about what we're doing in Texas related to PeriPAN and supporting women's mental health. So we're really excited to share all of the wonderful things happening in Texas with our colleagues across the nation who are trying to figure out how to support women in this pregnancy and postpartum period, as we know that suicide and overdose are leading causes of death in the first year postpartum. And when mom is not well, baby is not well. And so supporting mom supports baby's development and is a primary strategy to improve children's mental health. We continue to work on Wellnity. This is our resource database shared across the state. And we continue with the HB 18 implementation, as you have heard earlier today from Rachel, and multiple trait updates that I believe Dr. Williams will talk about, so I won't be redundant here, but Perry Pan is in the thick of all of those things as well and contributing to make sure that these platforms serve both projects well, both CPAN and Perry Pan. Next slide. This is a busy slide, but you might want to screenshot it or you can see it on the website. This is our our webinar and Echo series. Just wanted you guys to see it when we look at January through November. Our webinar topics, of course, are more didactic. We will give, 45-minute webinar, have some time for questions. And then we have an associated topic that we've collaborated with Be Well Texas that has something to do with the webinar topic for that month, but also for sure has a substance use component within it. And then we have both substance use experts and reproductive psychiatry experts collaborating together to deliver this information. And we have high attendance rates and high collaboration and discussion rates. And so it's a very exciting thing to have. Please attend, please spread the word if you're interested in these topics or think that they could help your faculty or residents. We also have, for any resident who attends these, we send them a special notice of an opportunity to meet with residents alone with a reproductive psychiatrist to really improve their education around reproductive psychiatry, especially the perinatal aspects of reproductive psychiatry. We know that information is not well represented across all of our programs in the state. In some programs, they have lots of didactics, and other programs, they're limited in the exposure they get to reproductive psychiatry, which is pretty typical across the nation. So we're excited to provide this resource and additional meetings for our residents so that they can improve their knowledge and confidence level in treating women during this time period. Next slide. That's it. That's all I got. Happy to answer questions.
Very good. Thank you, Dr. Wakefield, for all your work on this. Any questions for Wakefield, Sarah? I'm not seeing any. Again, thank you, Sarah, for all your great work on this. Good to see how it continues to grow. With that, Dr. Williams, Laura, we're going to transition over to you.
Okay, can you hear me okay?
I can.
Great. Next slide. It's Groundhog Day, apparently, so hopefully you're having a fun time. I don't know if we decided it's winter or not. It's been a little bit strange with the weather lately, of course. But obviously this slide, as Dr. Wakefield said, it's the reason for this slide to maybe stay on for the moment is just the number of providers. We continue to grow across the state as far as finding new clinicians to sort of engage and participate in the access program. We also are doing extremely well with responding to those calls. Again, within 30 minutes, not all providers want to call back in 30 minutes, but when they do, we're doing that 99% of the time within those 30 minutes. And actually the month of February or the month of January, it was 100%. Next slide. This is the same slide that Dr. Wakefield spoke about for CPAN related to the number of calls that we've had. As you can see, the very top line is the one that we're in at the moment. And we obviously have for ourselves a dip in the winter. I actually did look at the January data and we are bounced back for January. So next month, you'll see a higher number for our January data. But yes, we always have a little bit of dip as both clinicians and families are taking holidays and not coming into the office as frequently. Next slide. Similar to Dr. Wakefield, we have this sort of split as far as how often our calls are involving both our behavioral specialists and our psychiatrists. That's one of the things I do want to point out. It's usually not that they just want to speak to us. Even when they call us and want to speak to the psychiatrist, the behavioral health specialist is also often really helpful and looking for resources for the PCP and their families that they're working with. But nonetheless, we're glad to see that we're kind of hovering around this 40% mark when it comes to how often our child psychiatrists are getting involved in the consultative request. Next slide. These are our direct consultations. As you can see, pretty much since we started the launch during the sort of ARPA push for the direct consultations, we've seen a steady sort of increase from month to month overall, with the exception of whenever we have those dips that are more usually seasonal in nature. So good to see that. When you look at the data related to how frequently we're recommending the PCP consider a direct, how often the PCP is saying yes, and then how often the family or the woman is saying yes, we continue to track those numbers. And I think there's some interesting differences within them that sort of speak to the different patient populations and their needs. And certainly in a future meeting, we'll probably share that information and sort of chat about it with you, but just a little bit of a teaser. Next slide. As we've talked about many times this morning, HB18, we first, needed to discuss the plan about what we're going to do with the rural hospitals and clinics, which, spoiler alert, rural clinics are already part of our CPAN PeriPAN team. We needed to have an evaluation plan, also rollout plan, to your point, Nelson. And then we needed to make changes within our data system so we could track those things correctly and appropriately. Those changes are complete. And now we're sort of in that final phase of finishing the plan for the rollout. And then we will, the next bit of time, be rolling out to those rural hospitals and rural clinics, the CPAN PeriPAN consultations. The other thing that we are working on, of course, is the PCP portal. We're very excited about this. We are in our final stage with that as well. We're working on the communication plan to do the sort of go live. The portal itself is actually built and open and could be ready to go, but we want to go live with a sort of well thought out plan that includes all of our HRIs, the UT systems communication, so that we're all kind of working and swimming in one direction to make that portal launch be a success. And sort of speaking about what the things that the portal does, just briefly, as to Dr. Wakefield's point, talking about the PCORI grant, one of the things the portal can really help is help PCPs and support them in doing evidence-based measures for care. And so for PCPs that maybe are in smaller practices, rural practices, where they do not have the bandwidth to keep track of measures and to send measures out to families and women, one of the things that the portal will be able to do is do those things with the PCP's consent. And so we're really excited that the portal is not just a place to ask their consultation question, but also a way to support the ongoing education of the PCPs and their clinicians, and ultimately the families, but also to improve the type of care that they provide, which has been the goal of access programs since they first started over 20 years ago. Next slide. Again, one of the things we are working on is we're working with our end users. The work group has finally finished its sort of request for some redesign, some upgrades to make, now that we are as busy as we are, some of the things that are sort of the daily work that the teams do on their dashboard has gotten just bigger and lots more moving parts. So we've been doing some redesign for the dashboard for both the regular consultations that come in, as well as for when the direct consult. I'm sure, as you're aware, a direct consult just doesn't happen immediately. We have to call families, we have to call women, explain the program, get them to provide us consent. So there's multiple steps involved with doing a direct patient consultation. So the dashboard sort of has some upgrades as a result of that. The work group has finished their work. It will now go to UT System and the IE team to review the recommended upgrades, also CPAN leadership, PeriPAN leadership. So we'll have that sort of loop and close that out. And once we have a redesign that we're happy with, we'll send that off to the vendor. We did just create a new report that our teams have been asking for, related to how many teams were involved potentially in a consultation. Sometimes a team member is out for one of the HRIs, and so a call needs to transfer to another hub and sort of support that PCP in getting the help they need in a timely manner. So the teams have wanted to know kind of how those distributions occur. So we have our first sort of report related to that. We're having feedback provided to us, and as soon as everybody's happy with what that report looks like, That'll become a regular report that everybody will see. We've also been collaborating with UT System and IE to work on the experience surveys. It's an important element of our team to review feedback from PCP's clinicians about their experience with the CPAN PeriPan team. So we have our final process related to experience surveys that's now has been sent to the vendor for them to look at sort of the work and the timing for them to do that work. The goal will be to automate the experience surveys. Currently, what's required is for team members to, at a hub, remember, oh, that was a first-time caller, I need to send something, or this caller is called, you know, in the last 6 months, I need to send them something. So instead of our team having to remember to do that, the experience surveys will become something that is automated. The hope is that, similar to T-Chat, with an automated process, we will get a larger number of clinicians responding to the survey request. We have been working with WellNeti across both CPAN, PeriPan, and T-Chat to sort of improve what data we collect related to both the clinicians out there in the community who are providing various types of psychotherapies, treatments, and et cetera. So that process has kind of reached a conclusion. We're in the sort of testing phase of it, and then hopefully the next couple of weeks it'll launch for all the teams. Just similar to PeriPan, similar to PeriPan, CPAN has been working on our CME programming. We do have CME that will be enduring materials, similar, I think one of our compatriots, Dr. Amador, asked about that. So we are working on a process for our webinars, not our echoes, because echoes will sometimes be talking about actual patients. So we do not record echoes for that reason, but webinars do not. And so the webinars are being recorded, and they will be created to be developed as an enduring material, which means that a clinician could pull one of them down at a time at their convenience, watch the recording, and after answering some questions, get CME as a result. So we will have both the live webinars as well as the enduring materials. And of course, we've been working on just sort of the schedule for our spring. We had everything all laid out, so we knew a year in advance what fall and spring CME schedule looked like, but we are now in that push of the spring. That's it. T-Chat, unless you want me to pause.
Any questions on CPAN?
I see a hand up.
Okay.
Hi there, Dr. Williams.
Yes.
I was wondering, for both CPAN and PeriPan, do we have like a target number of providers that we're aiming for across the state? Yeah.
The short answer is all of them. The longer answer is that we have the list from the state medical board as far as who or what types of specialists within the state of Texas. And each of those teams have gotten that list. We work with the IE team sort of to create that master list that would be the denominator, for lack of a better word. I will let the IE team speak to that in the future, but it's a lot more complicated. Everything feels more complicated than you think it should be. But it's sometimes a little bit more complicated than I can just say right now. But the end goal is everybody who's considered a primary care physician in the state of Texas, family physician, pediatrician, OB-GYN, and then there's a few subspecialists within pediatrics, like adolescent medicine, developmental peds, med peds. All of those individuals, if they have those types of specialty backgrounds, we know who they are, and our teams are going out and attempting to tell them about the program and hopefully get them to sign up and participate in the program. We don't turn anybody away. So if somebody does call us and they're not one of those specialty types, we still will, help them, but our teams are not going out and trying to enroll every physician in the state of Texas, only the ones within those subscribed specialties.
So do we know what percent of the denominator, I think you said you're still working on the denominator. So I guess my question is, what percent of your target
are enrolled
prescribers are enrolled in either CPAN or PeriPan?
I cannot answer that question. That is, again, something the IE team has been working on. I don't know that they have it in their plan to talk about today, but certainly that will be something we can take back that the executive committee is an interest in.
Okay, thank you.
Sure. Good question.
Any other questions on CPAC? All right, seeing none, Laura, what we talk about TChat?
Okay. T-chat, next slide. Again, this should look very familiar to everybody at this point. It's the number of referrals that we're getting from the schools across the state of Texas. This year is the top light blue line, and there's been a little bit of number increase related to referrals than last year, but it's looking at like a much more similar graph. So it's hard to say if this is truly a steady state or not. We know that there's still plenty of time left within the school year, and some of the changes at the state legislature level related to schools and school districts, it may take a little bit longer to sort of unwind and people to sort of incorporate them. But we're still getting a pretty significant number of referrals, along with the seasonality related to when kids are not in school. Again, we are always open, even if school's not in session. We still have patients that we're seeing over the holidays and including over the summer. Next slide. Maybe. Next slide. I can't move the slides forward, so hopefully somebody is
Do
moving
you
them
see
forward.
the enrollment slide, Dr. Williams?
Okay, thank you. Sorry, they look so similar. It's hard to see, which is actually good that they look so similar. So again, just because a patient is referred from a school counselor does not mean that the patient is seen. First thing that we must do is obviously contact a family member, legal guardian, and see if they consent to the care. So there's always some room between referral and enrollment, but nonetheless, we are still having a really nice number of patients that are, their parents or legal guardians do agree to having a T-chat service. Thank you. Next slide.
Well, Luann Southern has her hand raised.
Oh, okay. Hey, Luann.
Hey, how you doing?
I'm okay.
Hey, I just have a quick question. So on the previous slide, it looked like there were, I was trying to see the number of, okay, so we're total students referred 120,368.
Uh-huh.
And then the next slide of the actual enrollment, it looks like between 3,000 and 3,500. Is that right?
So the one of the referral one is totals, not just in one month, but
so do we have
a really long time.
So do we have the totals like of the 120,000, 368,000 children referred? How many have been
enrolled?
Yeah.
That is a good question. The IE team did not put this on that slide. So I don't want to say right this moment, but that's another thing we can take back to IE.
But Laura, correct me if I'm wrong, but it seems like traditionally we run about 2/3 of the kids that are referred end up being enrolled. Rachel, that I'm right? Between 50 and 60, so a little bit less than that. So between 50 and 60% of the individuals that are referred to being enrolled.
Yeah. Yes, I think that again, the teams work really hard. We knock 3 times minimum. So once we get a referral that comes to us, the goal our team has is to reach out to that parent, legal guardian, to tell them about the program and see if they would like for their child to participate. Some of those referrals we never get to enrollment because we can't reach the family. In fact, that's more often the case, is that we cannot get the family to contact us. We do collaborate with the school. So if our team has tried maybe once or twice and we're still not reaching the family, we will reach back out to the school and say, hey, do we have the right phone number? Is there a better way to reach this family? So we do understand that families got a lot going on and they're busy, but we at minimum knock 3 times before we would close out a referral. Certainly if a referral is closed out, there's no penalty. If somehow like 6 weeks later, they call us back, we'll open the referral back up and see the family. So really the goal is to do things, obviously that the families would like. And so that process can sometimes take a bit of time, but yes, I think that Dr. Lakey's right as far as the number that convert to an enrollment, meaning that the family has consented to care. Good question. Next slide. So again, this is hopefully a very familiar slide for most of you at this point. The red line is the number of students in any given month that are being seen. So again, just eyeballing this, we have between 4,000 and 5,000 students every month that are getting services, and then the number of treatment sessions. Certainly, most of the kids that we do help are doing some type of psychotherapy, psychosocial intervention, which typically requires, to be seen every week or every other week. So again, those young people are having multiple appointments within any given month. Next slide. And so to that point, again, the vast majority of the patients are seen within our team members that are providing a psychosocial psychotherapy, case management. A much smaller percentage of the time are they directed because there is a need for it for them to see one of the psychiatrists across the state. Next slide. We are, so not, when I say the Royal, we're actually me and Jenny and Candy have been working on creating some training materials so that we can ensure that everybody has the same understanding across the state as the programs have just gotten larger with a lot more people engaged at each HRI. I want to make sure that everybody has the same consistent message about how to utilize our vendor for our data collection as appropriately as possible. We are doing a similar thing that we did within CPAN PeriPan, where we're creating statewide materials that will be for education. We have kicked that off with 3 topics. The topics are going to be created by a group of experts within the different categories. It'll still be reviewed by the CHC and the UT System Communication team to make sure that we're following best practices related to how we develop these topics and present them. And of course, we are only doing educational materials for TCHAP that will go to counselors and or teachers, as well as parents. No presentations that are directed towards children. We are working with the UT system related to HB 18 as far as how we make some modifications to our trait vendor. There's a couple of different sort of just technical questions, as well as largely how do we want the referral process to flow. And so as soon as we have that completely nailed down, then we'll send that work off to the trait team to make those updates. Jen has been working with so the HRIs are all aware that we have the ability, if they desire and their own hospital system would agree to, for there to be a connection between the trait system and their EHR. So we have our first HRI that has taken all of the necessary steps to sort of get to that first point of developing a connection. And so we're hoping that will launch in the next several weeks. Just as you're aware, with the other bill that related to reimbursement billing after the 4th session, 5th session, Kosh is just helping organize and providing information to the consultant. And then, although we didn't talk about the CPAN Summit at all, which my bad, we are having the CPAN PeriPan Summit in this week on Thursday and Friday. Simultaneously, while the UT system is putting this summit on for CPAN PeriPan, they're also working to develop the summit and Kosh is supporting that process for the TCHAT Summit that will be in June. That's it.
Very good. Any questions for Laurel? Before we jump into the governor's report, I want to catch up with attendance. There are several people that have joined us since we took roll call. Like William Southern, I want to make sure the record shows that she is here. Who else wasn't here part of roll call that would like to identify themselves? We have a list, but I just want to.
Hi, Dr. Amador here.
Dr. Amador?
Dr. Lee?
Dr. Bacato? Okay.
Yes.
And Dr. Chapa.
Dr. Chapa? Okay.
Nathan Maxwell.
Okay. Very good. Dr. Maxwell. And then Lee Johnson, I think you're out there too, right?
Yeah, thanks, Dr. Lakey. I was on previously. I just jumped over to the laptop.
Okay, very good. I just want to make sure I reflects that all you are here. Anybody else that I missed? Hearing none, Rachel, let's go to you for the governor's report.
So this is the governor's report as of December 31st, 2025. Thanks to our internal evaluation team for preparing this for us. You can see that we have now hit 80% of all campuses are now active in TChat. We've been hovering over that number for a number of months now, and are finally a little bit over 80%, and that represents 83% of the student population. Every HRI is getting very, very close to meeting our goal of getting every campus out of a planned status.
4.6 million kids basically now have access to their school to TChat.
We have just over 400 schools in an onboarding status and 370 of those with a planned implementation date. You can see that most of those were planned to go live, become active in January, with a few others later this semester and into the following school year. Here's our look at districts by ESC and their status. This month we did a change to include all statuses for all districts in the ESC list. So this does look a little different than what you've seen in the past. Here's a look at our growth over time, continuing on an upward trend. And then finally, reasons for declining, that top reason continues to be that the district has existing mental health providers. Any questions?
Any questions for Rachel? Yes, just one comment. It's more a request to the group. If you're hearing or starting to having conversations with any of the large ISDs that haven't been part of this yet, please let us know. Just want to make sure we aren't surprised that the ARPA funds are going away. Concerned that some of them may decide to come now and to join, and we need to make sure we resource that in a way that's right. So if you're starting to have conversations with any of those large ISDs that will bring a significant number of students on, please make sure we're aware of that. Octavio, I see your hand.
Yeah, thanks, David. Greetings to everybody. Quick question, and this may be too esoteric or too difficult to address in the governor's report, but there's any way to get a feeling heuristically maybe about the quality of the mental health care services provided by the HRIs to our school districts versus those that are deciding not to?
So one of the things that has more those long-term outcomes and looking at kind of improvements over time. And so that is kind of part of the plan evaluation.
Nagla, I can't hear you.
Yeah, neither can I. I'm with Laurel. I didn't hear anything. Sorry.
Okay. There, we're using two microphones, so hopefully that'll work. So part of the evaluation plan for external evaluation, as they're looking at kind of the long-term outcomes, is to look at those schools that are participating versus those schools that are not participating. They're going to be building kind of this evaluation. We knew that the long-term outcomes takes a little bit longer to get to, and we needed the measurement-based care. We needed to be able to get access to also some of the outcomes associated with Texas Education Agency. So that's some of the things that are going to be looked at for 2027, and then further kind of set that up as a regular evaluation.
Thank you, Nagla. Excellent. I think those metrics will definitely speak to the great work being done by the HRIs.
And I don't see us adding that to the governor's report, because the governor's report, we try to be very consistent with the data of the rollout and making it available. But again, that's why we have our great partners with external evaluation from UT School of Public Health to do some of those larger analysis of the impact of the consortium as a whole on various components of the work that we're doing.
Thank you, David.
Makes sense? Any other questions? All right. Seeing none. I'm gonna ask David Farmer to do a presentation, and the reason I've asked him is because he's involved in, I think, some great complementary work to the work of the consortium. They were able to attain, and they being a group of partners, the lead being the MHMR of Tarrant County, and working with UNT to get funding from HRSA related to improving the children's mental health system in Tarrant County. They've been working very closely with the initiatives of the Texas Child Mental Health Care Consortium. And so this grant that they have received is the Pediatric Mental Health Care Access Grant. There's several of us that are part of their advisory committee, but David has been one of the lead individuals. And again, I think it'd be good for them to share the lessons that they are learning, especially how the work that they're doing is complementing the work of the consortium through CPAN, HurryPan, and TPAN. So David, let me turn it over to you. Thanks for, I know I kind of pulled you into this, but I hearing some of these meetings, I think it's exciting work they are doing, and an area that we can learn about what you're doing there.
Thank you, Dr. Lee. So really, as we talk about this, we do, as Dr. Leakey explained, this is really going to talk about a collaboration between the University of North Texas and our partner for all of the Texas Child Mental Health Care Consortium projects, which is John Peter Smith Hospital. They help us in that administration of the projects, along with one of our MHAs, Tarrant County MHMR. And so it's been a collaboration that's come together. I'm going to talk to you. I'm first just going to kind of explain what we're doing some, and then we're going to have a couple of other members speak a little bit more specifically about how we're doing some of this. But the Pediatric Mental Health Advisory Council really grew out of an idea that was developed by Laura Kinder, who's the Tarrant County MHMR program manager. And so it was, as Dr. Leakey said, in reference to the PMHCA program person grant that they had, we were looking at how can we come together, okay, and figure out how to better leverage what we're all doing. And so the advisory council really is bringing together, and actually, if we'll go to the go to the next one, because I'm going to talk about the statement of work. But we put this up here to kind of help you get some idea. What we try to do is bring together participants from community agencies. But what we really wanted to do was to deepen our understanding of each organization's role in providing pediatric services. Because often we're all out there doing things, we just don't know what each other is doing. We don't really understand each other's funding. And so we brought everybody together. We're trying to encourage the development of sustainable, replicable partnerships and models. But we're trying to do that through collaboration, resource sharing, reduction of service duplication, and identification of service gaps. One of the things we're finding is that there are these gaps in between, and we're going to talk about that a little bit in a minute, between some work that our TCHAT program is doing with Tarrant County MHMR in order to be able to work out a process of referrals from TCHAT into MHMR for continued services. So we'll talk a little bit more about that as well. We're also trying to help define the vision and the region's visions for pediatric mental health care access. We're providing some leadership and leveraging community strength resources to achieve that vision. And then we're really taking a cross-sector approach. We're emphasizing strategies supporting children and families in their natural environment. So we're trying to look at childcare settings, schools, homes, community spaces, and healthcare systems. We've got these organizations working together. My colleague, Molly Lopez, Dr. Lopez, is co-chair with me for this advisory council. And so, again, you can see some of these are statewide, but most are local, looking at the North Texas area. How are we bringing these organizations together? If you'll go to the next slide. One of our colleagues from MHMR, Laura Schwartz-Gruber, is going to talk a little bit about, it's kind of small, it's hard to see up there, but we want to kind of talk about what's some of the structure. I talked about that cross-sector approach that we're taking. And so she's going to speak just briefly here about some of the projects and how they're coming together, they're intersecting, and how we're doing what Dr. Lakey's talking about. We're trying to come together, work together, again, to best leverage and to sustain these programs ongoing, to be good stewards of the money that we're getting, whether it be from the state of Texas or URSA or other grants that are out there. Laura, are you there?
Yes, I'm here. Can y'all hear me?
Yes, we can.
Okay, perfect. Yeah, so thank you for having me. These are our 4 what we call buckets for the PMHCA grant. And so we have perinatal connections, childcare, schools, and collaborative care. And within each of these buckets, we're able to partner with organizations within North Texas as well as across the state. And so we've done a lot of really amazing work. In the past, I've been a part of the project for the past 1.5 years. And so I've gotten to see a lot of expansion happening. And so wanting to speak a little bit about each of these areas. So for perinatal, we have the perinatal connections team. We offer navigation throughout our entire span for pediatric mental health care access. So you'll see that within each of these buckets. For childcare, we offer training for Early Learning Alliance and childcare associates, as well as multiple other childcare teams throughout North Texas. In schools, we offer that referral linkage between the TChat, which we'll talk about here in a minute. We also offer telehealth services, so providing the opportunity for kids that are seeing our psychiatrist, we can see them through their school appointment or through their school, do an appointment that way versus having to pull them out of school, then missing an entire day worth of academic time. And then also that's increasing the time spent for the parent as well, where they're not having to, leave work. And so then for collaborative care, we've partnered with 3 primary care locations. Specifically with JPS, we're right at the brink of being able to bill for that collaborative care modality. So I think we're up for the TChat discussion next, so I will pause.
Hello, everyone. My name is Tanisha Kennard. I am here as a representative of our HRI's TChat program. We see this as just one more celebration of what can happen when we're collaborating and working towards the same goal. As part of the LMHA TChat pilot that was led by Dr. Pliska and Rachel, we initiated an effort with Tarrant County MHMR specifically to try to streamline our referral process. As you are aware, there can be some things lost when you send a family to the LMHA and they're responsible for trying to figure out how to make those contacts, make those phone calls. And what we continued to hear was a disconnect with the family saying either they didn't get the call or they got the call, but they didn't know what to do, or our LMHA partners not receiving the referral. And so we thought that the solution to that would be to, one, make the referral as simple as possible, but also help have the systems talk to each other. Next slide, please. So this is small, but basically this is an overview of the workflow and a pictorial representation of what our written agreements are. So when our TChat students start the program, after we've got the consents and everybody's on board for the care, we immediately assign a case manager to each of those cases, and they begin their assessment process. If it's identified that a student may be appropriately discharged to an LMHA from our care, we initiate that referral immediately. That discussion happens with the family to gain agreement on the discharge plan, and we start that referral process. We were able to build our referral in our EHR to communicate electronically to
the Tarrant County's EHR system. And so our referral is just like any other referral that our clinicians would put into the system, which made it really easy for them. And on the LMHA side, they receive the student's name, information that is necessary for them to contact the student, as well as the case manager who made the referral, to keep in line with that closed loop communication. One of the factors that really identifies whether a student is going to be appropriate for Tarrant County MHMR for us is if that student has multiple service needs, meaning they will need possibly to continue counseling, but also medication management or anything else that may be appropriate. Once we got through the point of building the referral, which honestly took the longest part of the project, we were able to activate an Epic workflow in our EHR that sends that referral forward. But we also came to some agreements on response times by our LMHA to that referral. Laura, I know you're still on, so if you want to add anything, please do. We created 2 pathways for those referrals, one of which is an urgent need, and we have agreement with our LMHA that they will respond to those referrals within 1 business day. The other referral is a traditional referral, and for those 3 business days for response and an appointment actually scheduled within 30 days. Now, our workflow has been active. It really got going really good during the winter break. So we haven't had that many referrals go through the process, but we have tested the system and had at least a successful transfer of referral, a real referral to the MHMR system, and that has worked well. Our next steps right now, our closed loop communication is directly person to person. So MHMR will contact the program via phone. But our next step for this workflow as the referrals ramp up is to create a closed loop through that same electronic pathway, talking back to our EHR to let us know referral outcomes. Next slide, please. This is an example of what the referral looks like. For those of you that work in a similar EHR, you'll see this. One of the things we did in test with this is as we sent referrals back and forth, we worked with the LMHA on what information was important to them to receive in their system. Next slide, please. And this is what they see on their side. As you can see, there's an example there of a referred by contact, a diagnosis example, a specialty example, and where that referral was going to. Along with that, we are able to embed, of course, demographic information, medication information, and all of that is being pulled out of the EHR into the referral process. So it's not a manual step for our clinicians. So overall, we're really happy with the outcome. Shouts out to Dr. Pliska and Rachel and team for pushing that pilot along. We think that this actual workflow, we will be able to replicate beyond MHMR for some of our other behavioral health programs, and hopefully many people will benefit from it. Thank you.
So that's an overview of what we're doing, that, and we gave you an example of one of the outcomes that's and one of the products of this collaboration that we've created. So questions or team goals.
Very good. Well, I put up the slide that had kind of 4 pillars, and just kind of leave that up as we have the conversation. And again, I just thought it'd be worthwhile to share this information. Not having seen it, and how we develop it and the collaboration in the community. Tarrant County is always well known for bringing all these partners together to solve these issues. But just want to lay it out there as an example of the work that they're doing. And again, we'd love to hear any comments. Talk on the school part, but there's these other component, other pillars of this work. Any questions from anybody? Holly, any comments from you?
Dr. Linky, I think I would just share that one of the things that has been so impressive to me is how they have operationalized the idea of no wrong door, where kids, wherever they may be and wherever their parents may express a concern, or a teacher may identify, perhaps a developmental concern, that they have identified ways to get those providers, those caregivers, resources, and then help navigate them to the most appropriate care within the community, knowing that they have developed such a nice continuum of care from prevention to high need resources, and have just built a wonderful navigation system across partners to help families really get to where they need to be. Exciting.
And I think it's also a nice example of our state, PR funds, et cetera, partnering with federal dollars, partnering with local dollars, and not having those funding streams siloed, but really working and developing a system of care for kids there. I'm sure they'll, if you have any questions about what they're doing, they are available to answer those. And HRSA does on occasion bring these funding opportunities and make them available. And so if we see another opportunity, we'll send that out. But kudos to you guys for finding that opportunity, securing that opportunity, and putting it to work.
Thank you, Dr. Lee. Yeah, anyone, if you have questions, just email us. And we're happy to respond and talk about what we're doing, how we're doing it. If you have other ideas that you can offer us, yeah, we're certainly open to hearing those as well. So thank you.
All right, very good. Dr. Pliska, let's go to you and have the update on the data dissemination and publication.
Do not have any slides. The committee approved the two presentations that have already now are going out. One was that Dr. Shotwell and his colleagues presented some data on management-based care, various scales, HQ9, GAD-7, et cetera. Their use in telepsychiatry that was presented at the American Academy of Child and Adolescent Psychiatry last October. We also approved a manuscript from Dr. Williams and Kosh, which is basically an overview of the TCHAT program. That's still insufficient. I don't know, Laurel, if you want to say what you've heard or not from them. Or you may not say how we do it. And the committee is going to be reviewing two presentations with at the upcoming February meeting. One from the manuscript from the external evaluation team and a proposed project for the UTMB. A reminder to all members of the consortium, anything related to data which is going to be presented or you come to the data committee needs 30 days in advance. It's particularly important for meetings. Meetings often request that you just put in a slight abstract and then you submit the data later. I want to remind everybody that that abstract needs to be approved by the data committee. You don't want to get in situations where people have been told, yes, please send your full proposal, and then they come and they haven't had approval from us. There could be issues there. And in particular, the American Academy of Child and Adolescent Psychiatry deadline for this October meeting is February 12th. So basically, haven't requested approval. Has. It's too late to present any consortium data at the ACAP meeting. Now, if you're sitting there saying, oh my God, I submitted an abstract, you need to get in touch with me offline right away. We're going to get more strict about this in terms of enforcing these deadlines as the time goes on. Manuscripts is less of an issue because we have plenty of time to those. But at any rate, a final reminder is what is data? Anytime you're putting numbers in your presentation, it's data. So if you have a presentation that's simply a qualitative description of CPAN or TCHAT, that can go directly to communications people for them to review all the aspects of it. But anytime you say, we saw X number of kids for X number of sessions, then that becomes a data issue that doesn't need. Any questions?
Seeing that, Molly, let's go back to you for the update from internal evaluation.
thought we would take a few minutes at this meeting to provide a little bit of an update for efforts to continue to make actionable data available to the HRIs through a variety of Power BI dashboards. So we have two types of dashboards. We have both state level dashboards for presentations, and then we also have HRI performance dashboards. So I'm going to kind of remind you all what those are and then give you all a few updates. So our presentation dashboards, and here's just a little snapshot. These provide a variety of visuals that can be incorporated into slide deck templates. And teams have those slide deck templates for CPAN, PeerCAN, and TChat available to them. And they can use these dashboards to get the most updated, most recent data. They are updated monthly, so we can have kind of fresh data for those presentations. We are currently working on a new presentation dashboard for our CQB and CAT fellowship program, so we're hoping to have those available in this current year as well. All right, next one. So these are our performance dashboards. And again, we have these for the primary TChat, CPAN, and PeerCAN programs. And these dashboards provide HRI specific data that we hope is going to be helpful for understanding those key performance indicators that the executive committee and program leaders across the HRIs decided should be the focus for that year. And it also provides other data we consider sort of observational. And we hope that programs can use this data in overseeing and really guiding their work. So over the past few months in TChat, we have launched a few new observational measures. One is to summarize the outreach and training activities that the teams are taking part in by the type of activity that they're doing. We also have a visual to provide the proportion of students who receive 5 or fewer treatment sessions, which is our primary service model of brief intervention. And then we also have an opportunity to look at the median number of encounters following the first 5 for those who are extended to receive some additional services. And we can also explore what are the reasons that those extensions happen. And teams can do a little bit of Power BI magic where they can select a reason and see how it impacts median encounters and other ways of sort of interacting with the data. So for our CPAN and PeerCAN work, we have also been updating some of the performance measures here. We have released information about percent of consults that involve a psychiatric provider. That's data that you've been seeing acting these executive team meetings, so they'll have that regularly. As well as the percent of consults that involve resource referrals as a part of those. Additionally, there is outreach and training activities that happen in PeerCAN as well to help build and engage more and more of our providers. And so there's information provided there about type and the amount of time spent in those activities, as well as the percent of eligible consults that have a call return within 30 minutes. You saw earlier today that that's a metric that is going very well, but when there is a blip, if something is coming up, there's a chance to dive down into that and see a little bit more information about when that might have occurred, what might have been going on. And then also we have the percent of consults transferred to another HRI at each phase of the process, which gives teams a chance to look at when they might have either an opportunity to rely on the broader network of access programs to make sure we're still meeting the needs of providers and getting that timely access as well. So here are some of our next steps, some of the things that we're currently working on, and a little bit of a future look into the dashboards. So as I mentioned, we're working on a new presentation dashboard for CQB and CAT fellowship programs. And we're also ready to hear any requests that you might have for new data visuals that you think might be helpful in public presentations.
So as you all are using that data, if there are things that you wish that you had, that would be really helpful as you speak to it, let us know, and those are certainly you consider. We're also working towards with our CPB and CAT fellowship programs, starting to move towards the performance measures and observational measures that you see in the other programs. So the plan is that we are gonna kind of we've started developing some draft measures. Those will be shared with the program leaders across the HRIs, as well as the executive committee before they're finalized. And then when we have approval for final measures, those will get built into a new performance dashboard as well. And then from TCMHCC and CarePlan, we really are just in the first few months of looking at the performance measures and the observational measures, but it's time to start thinking about how those are working for quality improvement, whether they should stay as a measure for an additional year, whether metrics should be updated, and just how well they're working right now. So we're gonna be seeking feedback around that. And we're also gonna be ready to consider additional data visuals that might be helpful to teams in their quality assurance efforts. So even though we're kind of just getting going, it's time to start thinking about how do we continue to improve upon the dashboards and the measures that we're using for our own quality improvement cycles to make sure it's really meeting the needs of HRIs and the work that they're doing.
Any questions?
These to be accessed right now, and is there, where's the link or whatever, is this something that you have permission to specific people to access?
Yes, but right now we do have to give permission to specific people, and so there is a list available of who the HRI contacts are for each dashboard and each program. And of course it varies, so we'll certainly get you there. We're working towards a solution that might allow for a different way of accessing, but right now it is a bit of a limitation to certain individuals.
Someone in HRI as a designated person for your CPAN or for TCHATS, and
yes,
you could have them show you.
Yes, absolutely.
Any other questions? Concern? Yeah, we want to feed back to you as much data as we can. We want to make sure we do that in a responsible way. So that the people that need to see this data, the drive quality improvement have it, but it's not unique for any other purposes, but I can follow you. Let us know if go through this, if you see something that doesn't look quite right, let us know. This is part of that commitment of trying to get this information back to you. Thank you, Molly. Let's transition now, Laura. Let's go to you from Southern.
Hear me? Everyone hear me? Can you hear me now? Okay. We'll go to the next slide. We're going to present qualitative data that is going to reflect interviews we did focused on CP Week with the medical directors and some of the key program staff involved. So this evaluation focused on understanding the CPB program from the perspectives of these medical directors and the staff across all 12 HRIs. We conducted 12 virtual interviews between October 24 and January 25. And that included actually 9 of the medical directors and 12 program staff. So trying to get that perspective from on the training and building capacity goals. So again, these were kind of the broad themes, and we'll walk through. Next slide, some of the key themes. And we identified 6 key themes that emerged from the medical director interviews. Overall, directors expressed strong support for CPB's mission and impact, and highlighted the importance of partnerships with the LMHAs. They emphasized that hands-on exposure builds training competence, identify potential systemic and workforce barriers still limiting the program's full potential, and CPW's influences on trainings' career interests and understanding of the community psychiatry, and also on some insight on potential retention. And then finally, we looked at the satisfaction with the program, which we found was high. However, directors identified opportunities for continued structural improvement. So we'll go through each of these. Go to the next slide. So the first theme captures the strong endorsement of CPB's mission and its impact over time. Medical directors describe the program as both mission-driven and essential for addressing workforce gaps out in adolescent psychiatry. And many have been involved since CPB's inception and have seen it mature and expand. They credited the program with increasing access to care for underserved youth and enhancing residency training experiences. Even with challenges, directors consistently express strong commitment to sustaining and growing. Go to the next slide. This theme highlights how partnerships with the LMHAs drive CPB success and where those partnerships have encountered challenges. So on the positive side, some of the strengths are that the directors describe strong, productive, collaboration grounded in mutual respect and regular communication. Statewide meetings and monthly director calls were especially valued for promoting peer learning and problem solving. And challenges identified reflected that some interviewees described challenges particularly to site readiness, staff capacity, and differences in expectations between the HRIs and LMHAs. And in a small number of cases, the challenges were difficult and they affected training experiences. And we'll talk about that more. We have more in-depth understanding of that, but something to follow up on. Go to theme 3. This theme focuses on how CPB builds trainees' competence through real-world community-based experience. So medical directors describe the program as offering hands-on exposure to diverse populations and complex cases that residents wouldn't typically encounter in academic or private settings. They noted that trainees gain a deeper understanding of how social and economic factors, trauma, and access to care all influence mental health. Exposure to a range of clinical environments was also appreciated. From the outpatient clinics to emergency and specialty settings, these helped trainees develop adaptability, confidence in treating a variety of conditions. Directors view these experiences as foundational for preparing trainees for community psychiatry practice. A few practical challenges were mentioned, such as short rotations in some, scheduling conflicts, and limited staffing, which at times disrupted learning continuity. This theme highlights the structural and systemic barriers that limit CPB's full potential. Across interviews, directors consistently cited staffing shortages and administrative burden as challenges. They described how documentation requirements, outdated systems, and limited resources reduce efficiency and add stress to both the supervisors and trainees. And importantly, most emphasize that these issues stem from broader statewide system constraints, not from CPB itself. And the directors agreed that greater administrative and operational support would help the program function more smoothly and allow CPB to reach its full potential. So this theme focuses on how CPB influences trainees' career paths. Directors said the program raises awareness of public mental health and often sparks new interest in community psychiatry. Some residents have gone on to accept positions in community settings, while others continue in academic hospital roles. but leave with a stronger appreciation for the community practice. However, long-term retention means challenging barriers like understaffing and administrative complexity and limited flexibility can discourage trainees from staying in these roles. Several directors suggested offering leadership training and joint degree options to help prepare trainees for future system level positions and sustain their engagement in community psychiatry. And the last 6. This final theme highlights strong satisfaction with the CPB program alongside a shared desire for continued improvement. All medical directors rated CPB highly, reflecting broad satisfaction with the mission, flexibility, and collaborative design. At the same time, directors identified key areas where strengthening infrastructure could make the program even more effective, especially around administrative support and readiness and consistency in supervision. They also emphasized the importance of maintaining clear and streamlined communication across HRIs and MHAs. And despite these challenges, there was a strong sense of optimism and continued enthusiasm for the future growth and long-term impact of the program. The last slide is just a few limitations and next steps. So of course, this is qualitative data. So this is a limited sample and just provides themes for future understanding and more rigorous surveys, also through discussions. There is selection bias and who participated, and context settings also drive interpretation of this. So for example, there were rural LMHAs which may have had different perspectives than the more urban ones. And so for some next steps, this survey, we're going to be conducting surveys following up on this with CPB residents to set long-term career trajectories. And also we presented this discussion to LMHA leads and really got a lot of really good feedback from them on their perspectives that will help us inform kind of future qualitative questions we can go to them with and get that kind of full 360 circle on all the perspectives regarding these themes and new themes. And then just really quickly, these of course are meant to help generate discussion as potential areas for growth. For example, a theme about training and structure and support really can help understand how we can maximize that experience. You know, from themes 3 and 5, there were things that came out that we can't go into detail here, but providing housing or transportation support, especially for rural options, expanding leadership opportunities, and joint degree options like an FPH or MBA to strengthen long-term retention, to strengthen collaboration, site readiness, being related to themes 2 and 6, there could be some discussions around how to conduct early logistic planning with LMHAs, clarify supervision and scheduling, or to discuss how they may want to standardize onboarding and supervision processes across HRIs to ensure consistency, and then addressing low awareness or institutional engagement related to themes 1 and 4. There are further insights that could kind of inform future discussions about improving communication between the HRIs and LMHAs on roles, expectations, and shared goals, promoting CPD Week's statewide workforce initiative by increasing LMHA collaboration, sharing more of the program successes and positioning it not just as training into rotation, but also strengthening, remembering that it's strengthening the mental health workforce and really engaging in discussions around that, voting what's happening. So these are just suggestions again for CPD Week discussions, stakeholders.
All right, very good. We have time for any questions or any comments, interactions. Olga, see your hand.
Yeah, I think Lee is still on the call, right? Oh, there's Lee. I was wondering if Lee could provide some of his feedback or thoughts on this, especially as it relates to staffing shortages, administrative infrastructure, and documentation demands. Is that consistent with just what you hear day to day, or is that particular to this project? So my question is to Lee, if that's okay.
Thanks,
We'll let
Olga.
Lee jump ahead of Steve and,
Sorry, Lee.
All good. No, I was actually going to chime in and just say thanks to the team. We had in I guess it was mid-January, we had a great discussion during one of our own membership quarterly meetings with all of the CEO and executive directors from across all of the local mental health authorities. And it was a really fantastic discussion to talk about this. And I think we'll create some synergy and some opportunity for conversations ahead. I really appreciate Dr. Plitzka, your leadership on this front. And I think, you know, as we look at some of these challenges, like to your question, Olga, you know, workforce challenges are affecting every entity in healthcare today. It certainly affects our system. But I think, you know, in the feedback that we heard in the discussion in mid-January with our membership around this, when you have good communication lines and you have folks who are engaged kind of on both sides of this, you see better outcomes and better results. I was really encouraged by a comment from Wayne Young. He's the CEO for the Harris Center in Houston. And he specifically talked about protocols and things that have been developed to make the experience more beneficial to residents that are rotating through, and also make the experience better for their clients receiving care. They talked a lot about how the kind of rotation sometimes creates like a sense of, well, it's a new person every time I come in. And then they've been able to work out some strategies that allow for greater consistency, which I think builds in the positive outcomes and the kinds of things that we really want to see build out across the state in areas that are utilizing this program. And I think that moving forward, it's going to be really useful to continue to get that kind of two-way feedback. You know, really grateful for the opportunities. The team presenting the data today talked about, Laura, you did a magnificent job with our folks. And I think that there will be more opportunities ahead, I hope, for that kind of dialogue that will just continue to strengthen what's happening out there across the state. So I'll stop there, Olga. I hope I answered your question, but let me know if I missed the mark on that.
One of the action items coming out of this is Rachel and I are working on setting up. Sorry. One of the action items coming out of this, Rachel and I are working on setting up a meeting with one CEOs or their designate for the child programs to kind of talk about mutual areas of interest. I believe the external team also been tasked surveying the LHAs themselves. That is ongoing. So we'll get the view from their side. And ultimately, we want to kind of work out some of these systemic issues that either limit growth or cause difficulties either in delivering patient care or in affecting the service education balance. So that'll all be ongoing in the next
Any
year.
other comments? Well, that takes us to the end of the agenda today. I think it's a pretty fitting place to end. This is where we started the Sonya Games and how important community mental health services were. And to hear the word from Tarrant County, the collaboration, she was all about collaborations and how to bring people. I think she'll be pleased to see progress that has been made by that she influenced, that she had her hands on. So with that, this is the end of the meeting. Again, look forward to continued conversations until our next meeting. A lot of work related to the budget. Alex and had to talk about her open hours. Please feel free to reach out to her to work through your budget. We may seem a little bit early, but we really need to jump on that, so we're ready for not only this next year, and then for the next biennium. And legislative initiatives from last session, makes it sound like everything's moving forward well. And so, a couple of numbers that stick out in my mind. 4.6 million kids that have TChat available, 83% of the student population. The 3/4 of the people going through CTE going into nonprofit or public service. I think that's good. And continue to grow all the programs. With that, we're done. Thank you for your time. Look forward to talking to you soon.
Thank you. Thank you.